Remy, it's great to see you here, and you've been actually using this genomic classifier, the Oncotype DX, in practice. But could I take you back, first of all, to the St. Gallen meeting, I think it was 2009, where they had the consensus which gave support to the idea of using gene testing. What happened at that time, and do you think it marked a way forward?
Well, the genetic testing is not a recent information. The first data on that coming back to the beginning of the 21st century with works done mainly in Holland with the 70 genes test and several other tests. There was an Amsterdam signature, Rotterdam signature. And in the parallel, there was the development in Pittsburgh from Peck and colleagues of the Oncotype design. And the research is coming from each part of the ocean. And in a certain way, the war is not finished. It's still working, United States against Europe, and trying to do the best things for the patients.
So there are systems in the US and in Europe,
yes,
and both are representing a way of actually determining genetically what might happen to your patient with early breast cancer.
It's a little more complicated, if I can, because the management of breast cancer is in a constant improvement. Constant improvement means that there is never 50% of the management who is going to change 1 year because of the discovery of one test, of one technique, and so on. Because the main improvement is the early diagnosis, which means we have smaller and smaller cancer, and we are dealing with patients now in which the hope of survival at 10 or 15 years is more than 80%. So to make progress in the last 20% is becoming more and more difficult. And on the other hand, there is patient in which you are expecting a very good result because they have good usual prognostic factor, and they do badly, and we don't understand why. So the genetic testing came in addition from the size, the node, the grade, the lymph node invasion, to add more information, and in order in good prognosis patient to select the very good prognosis patient and to distinguish them from the bad prognosis patient. And as usual, there is in the middle the intermediate patient, which represent a constant situation in which we are facing difficulties.
Clearly, genetic testing could go into more widespread use. How do you recommend doctors to use it for their patients with early breast cancer?
At the present time in France, we are involved in a European trial called the MINDAC trial, related on the signature from the Amsterdam signature. In the United States, it's now widely used, the Oncotype DX test, using 21 genes, and to select in the small tumor with positive hormonal receptors and node negatives, with a little extension with the 1 to 3 node positive, to select the patient in which we can add some benefit from chemo, or in which chemotherapy will be of no benefit. And there is an important change because in the publication at the present time, there is about, between the teams, from 20 to 30% of the decision for chemotherapy, which is changed to hormonal therapy, and which obviously save money, but also in what we call the cognitive function of our patient, allow them to avoid a chemotherapy with all the side effects of the chemotherapy, which is, to my point of view, an enormous improvement.
So what do you do with your patients now?
Well, a patient is operated on, she has a biopsy, she's operated on, and then we discuss on the tumor, the nodes, the chest X-rays, liver test, and so on. And we meet in a consensus conference, local consensus conference. It's a multidisciplinary team conference. In French, it's called Réunion de Concertation Pluridisciplinaire, RCP. And then we discuss the best post-operative treatment according with the local referential. But it's life that there is patients who don't fit with the referential. So we need additional information. If, for instance, I take example, if you have a young patient, 35 years old, who has a highly aggressive cancer, 3 centimeters diameter, highly proliferative cancer, negative receptors, positive nodes, nobody will discuss about chemotherapy. I know the opposite. You take an old lady, 75-year-old, small tumor, negative nodes, positive receptor, low proliferation. Nobody will give chemotherapy to her. But when you deal with the perimenopausal patient, you know, the females are separated in before 50 and after 50. Before 50, you are young. After 50, you are old, which means you are menopausal, which obviously it doesn't work in the real life. But the consensus and the rules are very often decided on this cutoff at 50 years old. So if you are 49 years and a half old, and you have positive receptors, but you know, they are positive, but not so strong, and the estrogens are positive, progesterone are negative, there is a proliferative index in the middle, and you are in a difficulty to decide what to give as medical treatment. So as I said a little earlier in this morning, there is 2 solutions. Either there is a dominant male in the consensus in the multidisciplinary team, and the dominant male say, okay, this patient will receive that. So I decide my patient will never receive chemo. The other solution, which is a more objective solution, is to use a genetic testing in which this intermediate patient can be separated either in a good group or in a bad group.
So what you're describing is authority-based medicine in comparison with evidence-based medicine. Do you think the genetic testing can now give the evidence base for making those decisions?
It relates to evidence, but we are dealing with men, with females, of course, but it will not solve everything, but it will help us to improve the management of the patient. The advantage of the genetic testing is that they are objective, reproducible, and they can be shared from United States to France. While if you just look at a pathology on a slide, there is always some kind of subjectivity, what you call not evidence-based, but
authority-based.
Authority-based,
yes, yes.
yeah.
Yes. So you have then now, if you have a patient with a small tumour, estrogen receptor positive, that's a good candidate. There would have been doubt. What about HER2, for instance, and what about nodal status?
HER2 is simple. HER2 is simple, it's solved. It has a targeted treatment with Herceptin. So if the patient has HER2, the patient will receive Herceptin, and if the patient receives Herceptin, she will have chemo. That's no discussion. Nobody will discuss anymore, unless she is 80 years old, or if the tumor is less than 5 millimeters. But that's not anymore a question, HER2 patient.
What about nodal status then? How does that come into it? If you have a lot of nodes, does that mean you still don't need the test?
The genetic testing is used at the present time for selecting in negative nodes, or it's small node involvement. When there are a lot of nodes, the genetic testing will probably be used in the near future to select which drug to give to the patient. So to predict the sensitivity to a certain drug, which means, if I can interrupt you, there is two different ways to think. One is the prognostic way, and the second is the predictive way. The prognostic way is to say, Madame, your overall survival and disease-free survival is at 75%, 85%, 95%. That's the prognostic. The predictive way is to say you have positive hormonal receptor, so you can receive hormonal therapy. You have an HER2 patient, an HER2 tumor, so you have to receive a targeted therapy with Herceptin. That's true for hormonal treatment and targeted treatment. But for chemotherapy, at the present time, the only way to decide for a chemotherapy, until the genetic testing now, but the only way to decide was the proliferation. So the highest the proliferation, the highest the likelihood of being efficient with chemo. But that was not at all specific, and in addition, it was not specific of any kind of drug, which means you can give gemcitabine, adriamycin, cyclophosphamide, and that was no specific.
Has there been any clarification now, since the era of genetic testing, in the choice of cytotoxic chemotherapy?
It remains very complicated because of the heterogeneity of the tumor. And because in the clonal evolution, you can have some part of the tumor which can express certain genes which can predict their sensibility to a certain drug, and in another part of the tumor, some genes which are a demonstration that the drug will not be efficient. So we are really facing a difficulty of homogenization of the tumor, with the risk that if you select a certain clone of tumor which is very sensitive to the drug, the next clone here, which is not sensitive to the drug, will take a selective advantage, because they were living in sort of equilibrium of, if this one die, the other clone will develop.
And indeed, tumors evolve.
Yes, would eventually occur. But it's speculation, you know, that's still under research.
What about radiosensitivity? Can you do any predicting in that situation?
Well, that's a difficult question. I have to remind you that, first of all, I am a surgeon, but of course I've been working in Curie Institute, so I have some idea about radiation therapy. Now, there is some works in genetic testing and of predicting the radiation therapy sensitivity, and more of it to predict the side effect of radiation therapy, and in order to avoid the definitive side effect of radiation therapy with fibrosis or other stuff. But it's not yet used on an everyday basis.
So far then, we can get more refined predictive information for patients. What do you feel is the prospect of improving survival and improving morbidity, reducing morbidity overall among breast cancer patients?
Well, there is two parts in your question, because you say, how can we improve the survival and the quality of life? And would you like to live longer but in a bad condition, or a little shorter but in a better condition? And that doesn't relate anymore to medicine, that's related to philosophy. And obviously we like the targeted therapy, which reminds us bombing in some place in the Middle East, about the targeted therapy without collateral, not disease, but collateral damage. Yeah? So we try, of course, to avoid collateral damage, which is not very easy, and we discover from time to time with new drugs collateral damage which were not expected. clearly, the best way to improve the treatment is to, as well for the treatment and for the aesthetical sequelae, for instance, in breast cancer, is to discover the cancer at a very early stage. The earlier stage, the lighter the treatment and the better the result on a long-term basis, because it's easier, which it's quite evident, that's common sense. The bigger the tumor, if you come with a T4 tumor, it's a pity, but you are not, it's not necessarily obliged to cure the patient. But if you have a less than 1 centimeter tumor, then you have to fight to try to improve and not to let the patient with a strong side effects.
And because with refined detection techniques you can actually find these very small tumours,
yes,
then there may be a case for saying that genetic testing might be your best shot for finding out the
yes.
Aggressivity or benignity, if I can use that word, of the tumour.
One of the first answers is the smaller the tumor, so the genetic testing requires very small amount of tumor, which is in part of the question, because you don't have a lot of material to use to analyze and do the classical test, genetic testing, etc. So the genetic testing requires a small amount of tumor, and it are easy and reproducible. It's much easier in the American test, Oncotype, because it's done in paraffin, while the European tests are done on frozen section. And if you do a frozen section, you have to take a sample, put that in frozen section, and put another part of the tumor aside to do the classical test in order to compare them. So if the tumor is too small, you cannot do, for instance, MINDACT. The MINDACT trial is reserved to the patient with tumor 1 centimeter and over. When it's less than 1 centimeter, for instance, in my institute, our pathologists just refuse to do the test.
Mm-hmm. So where do you see the application of Oncotype DX principally then? In these very early tumours?
Yes, you can use very easily, because it's one of the slides of the pathologist which is sent to the referential laboratory, and it's very easy to use.
What then are your recommendations to busy doctors with worried patients who need to know what's the best way forward?
Do your best to get Oncotype, because it will improve the management of your patients. That's clear. The genetic testing in the good selected cases, which is the middle cases I talk you about, not the young, very aggressive cancer, not the old, very slow-growing cancer, but in the middle. And the use of genetic testing, and namely Oncotype, will help to improve the management of them.
How much would it improve risk adapting decision making?
That's change between 20 and 30 change of decision for chemo. So you will reduce the fear. All the patients with a cancer accept to be operated on. You remove the tumor, that's good. They feel better after the tumor is removed. But when they wake up after my surgery, they say, "Doctor, should I receive chemotherapy?" And receiving chemotherapy is considered as being an aggressive, a danger, a risk, something more dangerous. Their life is more concerned. And they know they will lose their hairs, no more eyebrows, ovarian function will stop, and that's not a good news. So if we can reduce the amount of patients who will receive chemo, it's clearly an improvement.
So potentially you feel that it's possible to spare patients treatment which isn't going to do them any good. Does the test using Oncotype DX help you decide which of the endocrine therapies to use?
No. At the present time, you have no test which can decide if tamoxifen or aromatase inhibitor is better. You usually use aromatase inhibitor because We have been reading international multicentric trials deciding that the aromatase inhibitor is better than tamoxifen.
But as far as chemotherapy is concerned, it looks now to you that it could be quite a help.
Clearly, yes, yes. If you can spare 30% of the patient the indication of chemotherapy, we all think it's an enormous improvement.